Okay. The common neurotransmitters that you see in these kind of situations is that the classics are acetylcholine, of course. Acetylcholine is extremely important as part of the parasympathetic system, which we'll go into that discussion in a lot more detail in a little bit. But it's also responsible for activating things like motor neurons, controlling like skeletal muscle. It's also important for contributing for arousal of attention and memory. Dopamine, on the other hand, contributes to control of voluntary muscle by doing fine modulation. It ends up being an inhibitor. If you have decreased levels in Parkinson's disease, you get the hyperaccentuation. You can also get the overactivity of dopaminergic synapses associated with schizophrenia. I think it's a disease process. It's also you get an elevated activity from cocaine and amphetamines. Okay. Norepinephrine contributes to the modulation of mood and arousal, and cocaine and amphetamines actually elevate directly the norepinephrine synapses. So what cocaine is really doing, as well as amphetamines, is that they're doing a dual effect. Okay? They're both activating norepinephrine levels, which that increases your mood, okay, and it makes you very alert. Okay? On the other hand, it also activates dopamine, which is also going to cause some other associated effects, including seeing abnormal activities such as what schizophrenics would tend to see. They may hear voices and things like that. So a lot of bad things may happen when you're doing that kind of stuff. Okay? And it's very unpredictable what will happen. When you stop taking the cocaine, what ends up happening is that you go through withdrawal, and your norepinephrine levels sometimes will get burned out if you're especially using high levels of it. And these people, as a consequence, don't have enough norepinephrine, and they go into a very depressed mood. And they go through severe withdrawal. Serotonin is a next neurotransmitter. It's very important for sleep. This also helps regulate the eating. Abnormal levels may actually have been found to be very much associated with depression and obsessive compulsive disorders. Okay? And endorphins, of course, are opiate-like structures. Actual opiates are like endorphins. That's what they should be, right wording. They basically bind to these receptors and down-modulate, and actually may give you a situation where you take away pain, just in runner's high, when you're doing like 7 or 8 miles and you hit a wall and you continue running, and all of a sudden you feel all fantastic and everything feels great. That's an endorphin rush. Okay? Now, the post-junctional receptors can either be excitatory or inhibitory. So in other words, even though you may actually cause excitation of that nerve, it doesn't necessarily mean that you're going to get an activation. You may actually get an inhibitory effect as well. Now, the electrical signals, the upside to it is that it's a rapid transfer of information. The long-distance information is conveyed rapidly to the desired location, and it's also very predictable. This allows the signal to have a one direction only, which is kind of good. Okay? The downside is an all or none phenomena with one threshold is reached, and so it's an on or off signal with no rheostat. Okay? So you can either get the action potential or you don't. Okay? So that's not something that you want in that sense. Okay? You want to be able to modulate your signal to do different things. So the actual electrical activity, which is what we're going to talk about right now, is how does that actually get propagated? It's done through transmembrane potentials. Okay? And the actual transmembrane potential, of course, is mainly responsible by the sodium-potassium ATP pump, which makes the actual negative potential inside the cell in comparison to the outside world. Okay? So the inside of a cell usually is around -60 to -70 if it's a pacemaker, an axon. If it's a motor muscle cell, you're looking at -95 because it needs more potential energy to do effective work. Okay? Without the ability to have a transmembrane potential, then basically death rapidly ensues. Now, what's responsible for this resting membrane potential, of course, is the lipid bilayer, which gives you a capacitance plate. The sodium-potassium ATP pump, of course, is critical, which we talked about before. And I'm not going to go into super detail about that since we already talked about it, with the potassium being pumped out for 2 times for every 3 sodiums pumped out. For 3 sodiums are pumped out, 2 potassiums are pumped in. There's also another important part that also helps drive the negative potential down is by the potassium leak channel. This allows potassium leak out of the intracellular space, which is a gradient of like 144 milliequivalents per liter. and causes the negative potential to be more negative. The pacemaker cells has a resting membrane potential that is rising due to slow sodium channel leaks. These are pacemaker cells like in cardiac cells. There's also pacemaker cells like that in your brain. What would be a pacemaker cell you think would be located in your brain? Breathing. Breathing has pacemaker cells. Anything that requires repetitive action without having to do volitional control requires a pacemaker cell of some type. So you have heart that requires a pacemaker cell. Okay? Your peristalsis would have pacemaker cells in them. Okay? Your GI tract. And you would have also peristalsis, breathing, which is movement of the diaphragm, would also require a pacemaker cell. These pacemaker cells can be located centrally or peripherally, depending on which organ you're talking about. For diaphragmatic, of course, control, the pacemaker cell is actually found in the medulla oblongata, which is in part of the brainstem, which we'll get into that. This is a pacemaker cell function. Okay? Actually, this is not a pacemaker cell function. This is a normal axon function with a normal resting membrane potential. Okay? When it doesn't have a changing phase 4, this one has a flat resting membrane potential. A pacemaker cell will actually have the phase 4, will be elevation. Okay? As soon as it hits threshold, okay, in this case, this one's getting electrical signal, it hits threshold, and then it causes depolarization. Okay? Once it depolarizes, what happens at that point is the channels close down, and then repolarization takes place. We have potassium opening up, and then the cell becomes negative in potential back again. Now, depolarization occurs only when threshold is reached. Okay? If you only get a small amount of electrical signal and you don't get full depolarization take place, then you don't hit threshold. Okay? But so you must have to reach threshold before the axon will propagate the signal. Okay? Once the threshold is reached, the axons themselves will have sodium channels that will open, and these fast sodium channels will then allow rapidly sodium to come into the cell and cause the channel to change to a positive deflection. So you're seeing here, this is a nerve cell. This is a rapid sodium channel here, and that causes this effect. Okay, so when you're talking about nerves themselves, you're talking about rapid sodium channels. Okay? Now, when you talk about cardiac pacemaker cells, you don't have rapid sodium channels. It has to do with calcium channels, which we'll get into that when we talk about heart. So it depends on which cell you're talking about. Okay? But most of the time, and unfortunately the book doesn't tell you that as well. They tell you sort of like they expect you to know that out of a clear blue sky, that what they're talking about is only about neurons. Okay? So the only thing we're talking about right now in this example is a neuron. Okay? And this is a non-pacing neuron. This is a regular neuron. Okay? So this is a neuron that's, let's say, an alpha motor neuron. This is the example of one. Okay? This is what it would actually generate the nerve signal would look like that. Now, what's really cool about this is that what you see about this is that it's very quick and on, up and on. Okay? The reason that's important is because it's generating a propagation of a signal very quickly downstream, and it gets it to the presynaptic terminal, which then causes the neurotransmitter release. So it doesn't have to do work. It just has to send the signal. Once the signal gets to the presynaptic terminal, then the calcium opens up and then causes the vacuoles to be released. So it doesn't really have to do a lot of heavy-duty lifting. When you end up talking about any kind of muscle cell, or any kind of cell that has to do work, then you'll see the occurrence of a plateau phase. Okay? So the plateau phase means that that cell is actually doing effective work. Okay? It has to keep the cell depolarized for extended periods of time for it to actually do functional work. Okay? But for actual neurons you're looking at here, you're just trying to send the signal quickly to have the effect that's desired. Okay? The cell membrane basically, through the threshold is reached, it becomes positive, it's depolarized, that's what it means. Once it reaches the threshold, it gives its maximal signal. Okay? In other words, it's an all or none phenomena. Once you open up enough sodium channels to cause the effect, all the rest of the sodium channels are going to open up at the same time. Okay? So it's going to send the propagation quickly. Okay, this is a classic example. What's asked always on all exams, and they're using again the example you're looking at here is just a neuron, okay, with a fast sodium channel and also a potassium channel, which is responsible for repolarization. Now, what's cool about this is that potassium is pretty much universally used throughout all the different cells as a repolarizer. Okay, so you can answer that pretty much in every test and be 100% safe when you say that what's responsible for repolarization, and the answer is potassium. Okay, potassium channels. Okay, as for what causes threshold to be reached depends on the pace on the cell you're talking about. If you're doing normal neurons, it's sodium channels. And when we talk about cardiac, we'll go into the differences between cardiac muscle and cardiac pacemaker cells. Repolarization occurs as sodium channels have to close. If the sodium channels are not fully closed, then that's called the absolute refractory period, which means that you cannot refire that nerve. As soon as the sodium channels are closed, then you can actually, if you put enough of electrical signal to that, you will propagate again another signal. Okay? So, but you have to have all the sodium channels first closed. During repolarization, potassium channels are open. And of course, sodium-potassium pump is continually working like a bilge pump. Okay? A bilge pump means that you've got the pump going on all the time. It doesn't care about what the cell is doing. It's constantly working. It just doesn't care. Okay? It's constantly trying to push sodium out and potassium in. The refractory period makes the axon unidirectional, which basically prevents it from repropagating back into the direction, which would be a bad thing. Okay. Now, the myelinated fibers require the nodes of NVA, which are regular interruptions of myelin sheath and neurolemma. They have high concentrations of sodium channels at these junction points and allow for rapid electrical conduction. These large axons transmit impulses at a faster rate, and they do it what's called saltatory conduction. They flow ions between segments of myelin rather than along the entire length of the axon. So it's much more efficient utilization of energy as well, because you're not having to line the whole cell membrane with sodium channels. Instead, it's only at the nodes of NVA. And you can see it's jumping from one point to the next. Now, the chemical portion of it, which of course is a neurotransmitter, the upside to it is that you can modulate the signal. You can actually release different quantities of neurotransmitter to get different effects. Okay? If I give a huge amount of neurotransmitter release, then it binds to more receptors and get more effect. If I want to get less in effect, then I release less modulator and get less receptor binding and get a less in effect. Okay? So the other thing that you can actually select out the neurotransmitter to either be, of course, inhibitory or stimulatory. Dopamine is an inhibitor, so is GABA. Okay? And you have your acetylcholine and norepinephrine are all stimulatory. So you can actually select out which neurotransmitter you want to use to affect the other cell. The downside to it is, of course, that it has high energy requirements. Okay? And it's slower, and it's more complex. And anything that has more complexity is more likely to do what? To fail. Very good. In other words, keep it simple, stupid. It's the best answer in life. Okay? But with these kind of things, everything's very complicated. There's a lot of systems that are in place to try to keep it nice and safe. But you can have a lot of disease processes that can actually affect these sites. This is what actually you're looking at. This is another example of what we were talking about before. The axon sends electrical signal. This releases the calcium to influx, causes the vesicle to release the neurotransmitters. Then they bind to receptors, okay, and they have their effect back here into the receptor, into the actual postsynaptic cell, whatever it is that you're binding to. Make sure that you understand something. This is an example of epinephrine. Norepinephrine is the main neurotransmitter. Sorry, norepinephrine is the main neurotransmitter for the sympathetics at the postganglionic axon. Okay, that neurotransmitter is different than acetylcholine in the sense that it does not have an enzyme that breaks it down at the actual postsynaptic membrane. What it does is it reuptakes the molecule, and when it reuptakes the molecule, it can then be broken down by MAOA or COMT to be reused. Okay? In addition to that, you have a secondary modulator to suppress the effect. Okay? And that's done by alpha-2 activation. Yes? Okay, I'll try not to turn my head anymore. Is that better? Okay. Is that, okay. Okay. What I'm going to do is I'm going to teach this way, if you don't mind. That way I can look at the screen at the same time. Is that okay? Okay. What you're looking at here is the norepinephrine is the neurotransmitter the sympathetics use. And one of the things that will happen is that norepinephrine is such a strong agent that it'll eventually end up burning out the nerve terminals, and it'll start causing a lot of downregulation. To cause that from happening, there's a specialized receptor on the presynaptic receptor called an alpha-2 receptor. Most students have a really hard time with this, so you understand this, you'll really push ahead and understand a little bit more about clonidine. Okay? This alpha-2 agonist activity then comes back here and inhibits the release of neurotransmitters. So it's basically a negative feedback system to suppress the neurotransmitter release. Now by knowing this, we actually give these patients a drug called clonidine. Clonidine is an alpha-2 agonist, and because of that, it begins to cause an accumulation of the neurotransmitter inside the presynaptic terminal. Now, imagine that normally there's only 10 little vesicles containing neurotransmitter. Okay? When you give somebody a clonidine, because it acts like a dam, it begins to cause the membrane not to allow these neurotransmitters to be released. Instead of now having 10, now you have 20, and if you really are chronically on clonidine, you could be as much as 100 vesicles at the end of the neurotransmitter, at the end of the presynaptic terminal. Okay? So if you stop giving clonidine to that person, what do you think is going to happen? Right, they get this huge rebound hypertension. Okay? So it's very dangerous. So clonidine is one of those effective drugs for hypertension because it prevents release of norepinephrine, which doesn't cause vasoconstriction. The downside to it is if you stop taking it, you can actually die from this. Okay? You get a massive overstimulation and release of neurotransmitter. Now, the other inherent danger of this is, let's say you're on clonidine and you decide that you want to be on cocaine. Okay? Cocaine actually acts as an enhancer to release these neurotransmitters at a higher frequency rate. Okay? Now, the downside to that is if you have somebody who's on clonidine, the effects of actually cocaine will be significantly suppressed. Okay, so this person is doing cocaine and doing their clonidine every day. Great. Okay? But then they decided that, you know what, I'm going to stop my clonidine. Okay? So they're already getting hypertensive. And then they take the cocaine on top of it. So that becomes fulminant hypertension, and the person dies on the spot. Okay, so, and you have to be careful with that too, because let's say you have somebody who comes into the hospital, you don't know is doing cocaine, and you give them clonidine, okay, then you may actually cause this cascade event to take place. So you always want to make sure that the person's not doing anything illegal when you administer this kind of drug to them. Now, what are the chemical signals that are available? Of course, the nervous system has inhibitors as well as activators, which you talked about. GABA being one of my favorite friends because it actually helps me deliver anesthesia. GABA agonists, which is propofol, pentothal, barbiturates, and all your benzodiazepines are GABA agonists. They act by suppressing the central nervous system and downregulating the nerves enough that it actually causes you to stop the electrical activity enough to cause sleep, okay, or what we call an anesthetic state. You can actually sometimes reverse that effect, okay, by giving somebody what's called a GABA GABA antagonist. Doxapram is a GABA antagonist. The downside to these medications, if you take inhibitors away quickly, is what can you cause? Seizures. You can cause seizures and convulsions that are pretty serious. So you always be careful with those kind of agents. That's why we don't use them. The way we let the GABA inhibitors stop working is we don't give reversal most of the time. And we just let them wear off and let them be metabolized. So the idea of actually using a GABA inhibitor is not such a wise thing most of the time. Okay? Activators, on the other hand, are acetylcholine. Okay? Those are part of the parasympathetic activity, but it's also part of the sympathetic activity as well in the presynaptic terminal, which we'll talk about in a little bit. This is a nice picture showing you how complex the whole system is in the sense of the cell body, followed by the axon going out, eventually going to the next cell, which then causes neurotransmitter release in between. Now, We're going to go talk now from nerve to nerve. Now we're talking about nerve to muscle. So we're going to go into a little bit more detail about what happens to the muscle. Okay, the neuromuscular transmission is critical for you to understand, because if you don't understand this, you won't understand what depolarizing muscle relaxants do. You will not understand what neuromuscular competitive blockers do. Okay? You will not understand why we reverse patients. Okay? You won't understand what train of 4 is. You won't know what tetanus means. So all the stuff that we do to control muscle function under anesthesia will basically be lost to you. So you have to understand this. Now, the second thing that I want you to know before I start talking about this is that neuromuscular transmission, okay, by inhibiting it, it doesn't mean that you're inhibiting the central nervous system. Okay? Actually, I went to a major medical center one time I was helping train people at the time, and I went to the emergency room and found out that the emergency doctors thought that the patient was receiving Pavulon for induction, and they gave lidocaine. And their answer was the patient wasn't moving, so they were asleep. That could not be farther from the truth. The person is totally awake with a muscle relaxant, which is a non-depolarizing muscle relaxant, but you have not suppressed the nerve endings at all. So acetylcholine hasn't been affected. You haven't affected norepinephrine. So those people are totally awake, but they just can't move. Okay? So it's not appropriate to give somebody a neuromuscular blocking agent who is not receiving adequate levels of amnesia or analgesia. Okay? That's not what we do. Okay? So understanding that difference is clear. Okay? Neuromuscular transmission is the ability for the central nervous system to act on the muscle. In this case, we'll talk about skeletal muscle, which we say the thigh muscle is an example, to cause it to control its actual contraction velocity, as well as its contraction force. Okay? This is a very highly specialized nerve that comes out of this spinal cord called the alpha motor neuron. That alpha motor neuron is a single nerve that travels outside of your spinal cord directly all the way down to the muscle. So there's no connection between that alpha motor neuron besides that axon all the way down to the muscle. So anything that cuts it, guess what? You lose the motor function. Okay, so it's only one nerve. There's no other cell body outside the spinal cord that generates that signal. Okay? Now, one thing you should learn is that every time that you talk about acetylcholine, the first neurotransmitter that is released from any nerve that comes out of the central nervous system, no matter if it's parasympathetic, sympathetic, or motor, is always what? Acetylcholine. That's a really big plus if you know that one. Okay? That's a good test question. If somebody asks you about presynaptic binding sites, sympathetics or parasympathetics for acetylcholine. If it's skeletal muscle, because it's the first binding site, it's acetylcholine. Okay? The differences between the sites is the different kinds of receptors. Okay? The receptors in the skeletal muscle are the nicotinic receptors. Nicotinic receptors. They're different than the other receptors that are found in the parasympathetics and the sympathetics, which are the muscarinics. Okay? The nicotinic receptors actually will then bind to these acetylcholine that's released. You get a modulated response. There's, of course, the acetylcholine receptor is critical. Okay? We'll talk about a little bit more in detail what the acetylcholine receptor is. Then we'll talk about the neuromuscular junction, the events involved in neuromuscular transmission, what happens once the acetylcholine binds to the neuromuscular junction, what happens when the action potential is propagated into it. You get calcium entry into the axon terminal. This releases acetylcholine, which then diffuses the acetylcholine across the synaptic cleft. It combines with the acetylcholine with the receptor sites in the motor end plate, and this produces the motor end plate potential. Okay, notice that what it's telling you by this example or this kind of slide is that you're causing the acetylcholine molecule to bind to a receptor. It opens the channel, and then it causes the cell, the skeletal muscle, to depolarize, which was what we call the end plate potential. Okay? That depolarization force, how much of the actual acetylcholine receptors open and depolarize, will then cause the secondary effect, which is the action potential will change, and it will lead to a voltage-gated effect on calcium release from the sarcoplasmic reticulum, which is a specialized structure that's inside the skeletal muscle that's right next to the actual contractile component of the skeletal muscle, which is the actin and myosin. Okay? The actual calcium, once it's released into that cytoplasmic structure, will then bind specifically to tropomyosin troponin complex and cause a configurational change, will then cause muscle contraction to take place. Okay, so eventually what eliminates the contraction is the actual calcium reuptake, and then also acetylcholine has to be shut down so you don't remain, cell doesn't remain depolarized, and that's done effectively by an enzyme called acetylcholinesterase. Okay? Now, why is that all important? Because if I give you two separate drugs, if I give you a depolarizing agent like succinylcholine, a depolarizing agent means that I bind to the acetylcholine receptor site, and once I open it, I keep it open. So the cell stays depolarized. So the muscles begin to contract, but once it begins to contract, the voltage gate of the calcium channels will close back down even though it's depolarized, and it won't reopen again. So the muscle becomes flaccid. But initially, when you give a depolarizing agent, you'll see the person contract. Okay? On the other hand, if I give you what's called a competitive inhibitor, okay, such as, let's say, Pavilon or Becuronium or Atracurium, those bind to the receptors, do not open up this acetylcholine receptor at all, but basically prevents acetylcholine from binding to those sites, and as a consequence, you get no calcium release and the muscle becomes flaccid, simply because I can't cause the acetylcholine receptor to open up. Okay? Now, the way we take off competitive agents is we can compete to get them off. And the way you can compete to get them off is you can increase the acetylcholine levels and cause those molecules to push off the competitive. The way you do that is by inhibiting acetylcholinesterase, okay, which breaks down acetylcholine. So because you stop the breakdown of acetylcholine, then the acetylcholine levels rise very rapidly in this junction, okay, and that helps push off the competitive inhibitor drugs. Okay. Now, let's go into the pictures, because I love pictures. Okay? This is a neuromuscular junction. Okay? Neuro, right here, this is a neuron, and this is the muscle. What's really cool about our bodies is that for every muscle fiber that you have in you, you have a nerve that comes in and binds in an isolated area. Okay? So it's a very small, discriminate area of the muscle that has these receptors. It's not all over the place. Every once in a while, you'll get a disease process where you get what's called efferentation, which means you get a cut in the nerve going to that. Either it can be from burn injury, spinal cord injury, ischemic events, electrical injuries, electrical burns. Those can actually cause the actual axon to be damaged. Okay? And as a consequence, these actual these acetylcholine receptors, which are nicotinic receptors, will not stay here. They will be increased tremendously and will cover all the muscle wall. Okay? Which is why when you give that person succinylcholine, you will cause them to die. You will cause them to have a massive depolarization event, and then it repolarizes and it causes massive potassium release and causes hyperkalemic arrest. Okay? Those are called neonatal receptors. But under normal circumstances, the actual density is actually very small in the area for actual acetylcholine receptors on the muscle surface. Okay, so when you give these drugs that we give, it actually going all the way down to here and actually binding to these individual receptors that we're talking about. Okay? Now, what you see is that when the neurotransmitter release, in this case acetylcholine, occurs at the nerve impulse, okay, it releases the neurotransmitter after calcium, ionized calcium is coming in. So if you have somebody who is hypocalcemic, okay, one of the things that you will see is that their muscle will lose its ability to contract properly. For two reasons. One is you won't have enough to cause the muscle to contract down here, but also you'll have a loss of neurotransmitter release, so that person will not have a good effective contraction because it doesn't get effective depolarization to take place. Now, the acetylcholine receptor, which is a number 2 here, is a specialized structure combined with 5 different components. It is basically made up of 5 separate protein helical chains, one called 2 alpha, 1 beta, 1 gamma, and I think there's one other beta, I think. I have to look it up again. Anyways, but there's 5 components to it. Anyways, the only site where it actually is important is the alpha. makes kind of sense. A to A. Keep it that way. Keep it simple, stupid, right? That's the way I do it. Okay? So two acetylcholine molecules must bind to cause a conformational change to take place. So if you only get one binding of acetylcholine, guess what? Nothing happens. If you have to have, in other words, two acetylcholine to bind to every acetylcholine receptor to cause that protein to change its configuration and allow rapid influx of sodium, which then causes a voltage change inside the muscle cell, which then releases calcium from the SR and then causes the muscle contraction to take place. Okay? Does that make sense? Did I lose anybody? Yes? Okay. Look at this example here in this picture. This is a very simplified, and I'll show you a much more complicated picture, I think, later on. Okay? This is a muscle cell. Okay? And this muscle cell, it has inside of it, very much like an endoplasmic reticulum, a specialized structure called the SR. It's called the sarcoplasmic reticulum. Okay? It almost essentially looks like the same thing as a smooth endoplasmic reticulum. Okay? But what's interesting about this structure is that it has inside of it, instead of having specialized proteins to produce more proteins and stuff, it actually has very high concentrations of calcium inside of it. Okay? When you depolarize, this is a voltage-gated channel, which means that as the voltage changes inside here, that voltage will cause that channel to open up. Okay? So once that channel opens, it releases massive amounts of calcium outside into the cytoplasm where the actin and myosin filaments are located at. And that's what causes the muscle to contract. Okay? Make more sense? Okay. Okay, this is my friend, the acetylcholine receptor. I was right. Okay? It's got two alphas. Okay, you can see this is where the binding sites are at for acetylcholine. So you have the 5 subunits. Okay, you have beta, gamma, and delta. Okay, these are the different components to it. And the only 2 sites where you get acetylcholine binding are to these 2 alpha helical structures. Okay. And you can go into craziness and look into this. This is eventually what I expect you to know for your boards. Okay, so this is, you have to know this by heart. This should just become part of your everyday vernaculum in anesthesia. Okay, if somebody asks you what is it that a neuromuscular junction does, you should be able to draw this out in a matter of about 30 seconds. So I expect you to know that for your exam as well. Okay? Now the muscle receptors, which are the acetylcholine receptors in the muscle, are nicotinic receptors. And that's very specific. Okay? And the reason that's important is because that difference between we would have really big trouble if we had the same receptors in the sympathetic system and the parasympathetic system, because when we would give the neuromuscular blocker, we'd be blocking out the autonomics. So we don't do that. That's good because it's a different receptor. The receptor in the autonomics is the muscarinic receptors, okay, versus the ones in the muscle are nicotinic receptors. Okay, keep going. Drugs, chemicals, and diseases. Okay, we went through depolarizing drugs already, how it actually binds to the acetylcholine molecule. Succinylcholine is two acetylcholine molecules connected up by carbon chains. Okay, so it's actually 2 bound acetylcholine molecules held as an arm shape. So what happens when it comes into bind to the receptor, it holds onto it and it holds it still, and it doesn't allow it to be broken very easily. Okay. The non-depolarizing muscle blocking agents are competitive inhibitors. Okay. If you were to use non-competitive inhibitors, you're looking at poisons basically at that point. There are poisons that are non-competitors, okay, that will block muscle only. The downside to that, of course, is that you can't reverse them, and you have to metabolize it for it to go away. Okay. You can also have substances which block the release of acetylcholine will also have that effect as well. Okay. You can also have downregulation of the receptors, such as the myasthenia gravis, where you have destruction by antibodies against the acetylcholine receptor. And you can also have things that affect substances which inhibit acetylcholine esterase themselves, which can either give you an overstimulation or lack of breakdown of acetylcholine, which is what we do, which is the neostigmine that we give. Now, what you're looking at here is the neuromuscular blockers can be broken down, am I blind, into, let's see what I write down here. Is it out of focus or just my eyes? Okay. What I've tried to do for you is to give you a little bit better understanding about the neuromuscular junction and how it can be bound to different kinds of proteins. If you're looking at the acetylcholine receptor, which is in the muscle right here, that's the nicotinic receptor. The nicotinic receptor can either be an agonist or an antagonist. Most of the time what we're talking about is antagonist, which means we're antagonizing the effects. And those can be broken down as depolarizing agents or non-depolarizing agents. The non-depolarizing agents, when you go into pharmacology, please understand that you should have this major family heading of the benzoisoquinolones or the aminosteroidals. Okay? When they start talking to you about non-depolarizing muscle relaxants, you should begin to separate these out into these two different components because they have different family characteristics. Benzoisoquinolones all release, to a certain degree, histamine. As a consequence, they all cause hypotension to a certain degree, depending on how fast you introduce the medication to the patient. The aminosteroidals, on the other hand, tend to be a lot more cardiac stable, okay? And because they don't cause histamine release. Okay? So different drugs do different things based on their family groups. You also have the acetylcholinesterase drugs that we use. Acetylcholinesterase drugs that we use tend to be antagonists. We tend not to use agonists most of the time. We use anticholinesterase inhibitors. Okay? We also have things that like calcium channel blockers that are antagonists, okay, which also begin to affect muscle contractile ability. Histamine receptors are also important in the sense that there are antihistamines that are antagonists. So these are the different kinds of proteins that can be bound by different things. Now, what you can see in different diseases is you can see a receptor malfunction. You can actually see an upregulation or a downregulation effect. Okay? An upregulation effect will cause you to have a much accentuated response when you do get the neurotransmitter release. So you can get excessive upregulation from excessive actions of depolarizers, and they can become extremely resistant from non-depolarizers. Downregulation of receptors gives you resistance with depolarizers, okay? Which means that if you have, with depolarizers, what you have to actually take place is that the cell has to be depolarized for the muscle to relax. So if you don't have enough receptors, then you can't get that action to take place. So in essence, people that are downregulated on receptors are resistant to the depolarizers. On the other hand, the non-depolarizers, if you have limited amount, you basically will flood it with a competitor, and then you have a much excessive action. So in downregulation is much worse when you give it to somebody a non-depolarizing agent in that situation. Receptor destruction may also occur like things like myasthenia gravis. You can also have diseases that actually cause anticholinesterase destruction, which then causes an overproduction of acetylcholine, or not an overproduction, but rather an overextension of acetylcholine at the neuromuscular junction. Okay? You may also have the intramuscular diseases, which is either you have diseases that actually destroy the actual actin and myosin, like muscular dystrophies. And you can also have sarcoplasmic reticulum diseases, which are important for our job, which is malignant hyperthermia and neuroleptic malignant syndrome is where those diseases are taking place. Now, why is that? Well, because muscle activation from malignant hyperthermia leads to the calcium channels to stay open. So the calcium just keeps pouring out of the SR, and you don't get the shutdown effect that you normally would expect. Okay? There's a site protein configurational change in the actual calcium channels in these kind of patients, and as a consequence, when they get activated, it leads to rapid release of calcium, which increases your basal metabolic rate just simply from the increased contractile velocity. Okay, so we'll stop there on that one. We'll start on the central nervous system next. The central nervous system can be broken down into everything that's encased by bone. Okay? And this example that I want to show you here is you have the cortex here, which is the cerebrum, which is number one. Okay? That's pretty much what makes us human beings. Without a cerebrum, you wouldn't be who you are. Okay? Cerebrum is broken down into 4 major lobes: frontal, parietal, temporal, and occipital lobes. Okay? And we'll go into more detail of that in a minute. Okay? Inside the next portion, which is the reptilian part of the brain, makes a more basic portion of the brain. You can still be alive, but you won't be able to think, is the diencephalic area. Okay? The diencephalic area is in the middle portion, which contains thalamus, which is important for conveying sensory information back to the brain. It's where the actual sensory inputs are coming in before it's in out to the cortex. Then you have the hypothalamic area, which is partly important for the autonomics, prethalamus, the subthalamus. Then you have the basal ganglia, which is also important in many different structures, and I'll show you that in a minute. And the cerebellum, which is extremely important for fine motor control, which is back here. That's the cerebellum. And then you have your brainstem that's broken down into 3 parts, which is the midbrain, okay, pons, and medulla oblongata. Okay. These portions of the brainstem each contain 4 cranial nerves associated with them usually. There's a total of 12 cranial nerves that you have to deal with. And of course, there's spinal cord, which is down here. That extends all the way from the foramen magnum all the way down to your L1, L2 layer, mostly L1 in the adult, L2 in the child. So the spinal cord is critical for not only sending information into it, but also sends out information as well out. The peripheral nervous system is basically anything outside the bony encasement. Okay, includes your cranial nerves and spinal nerves. Okay, once they leave through the holes in the heart, in the skull, which is called foramens, they become nerves. Okay, in the sense, cranial nerves control the head and neck. Also, the cranial nerves are extremely important for autonomic control mechanisms, such as the vagal nerve. The pathways in these kind of nerves, they send both afferent or ascending information as well as efferent or descending information. If you look at us from the standpoint of actually how we develop, is you can cut us in half and lay us out like a tube. Okay? If you look at us in the fetus, okay, we were initially one single flat pancake. Okay? And then as a baby develops, he involutes and forms a tube. And that tube formation is important in the sense that if you look at it from the standpoint that imagine that you have the central nervous system is directly in the middle of that flat pancake, okay? And you can actually put 3 pancakes on top of each other. Okay? The first pancake layer is the skin. The second pancake layer is the autonomics. And the third pancake layer is motor. Okay? And then take that tube and flip it inside. If you do that, you already begin to understand how the structure is made in the central nervous system. Okay? So you have a somatic component, an afferent component, and then you have an autonomic component. Okay? The afferent component, which is the bottom pancake, which is what is exposed to the world, is the sensory information that's coming back at you. Okay? So it makes sense. If it's on the bottom portion, then the nerve impulses it's going to go to is to which portion of the bottom of the pancake? The posterior portion, called the dorsal columns. So all the dorsal portion, which is the back of your back, posterior part of your spinal cord, that's all sensory. The next layer, which is the in-between layer, is the intermediolateral tracts, which is where the autonomics are at. And the top pancake is where the motor's at, and that's the anterior horn. So the top part of the pancake is where all the muscle nerves are going out. Okay? If you just see that allegory, things make a lot more sense the way they're laid out in the spinal cord. Okay? If you don't, then think of something else that may work for you. I've been struggling with this for years, so but that's what makes sense to me. Somatic nervous system, of course, is with the motor pathways regulating voluntary muscle control of skeletal muscle. It also is a system that sends afferents back as well to actually give you feedback. The autonomic nervous system is the sensory as well as motor pathways that tell you what's going on inside the internal environment, and it controls the internal environment. These pathways include the sympathetics and parasympathetics, which we'll talk in a lot more detail here in a little bit. Now, the actual cortex of your brain is actually a very complicated structure. Okay? If you look at our brains, they're not just smooth without any kind of indentations. Instead, we have these like valleys. Okay? These valleys are called gyri. Okay? I'm sorry, sulci. And the gyri are the actual top of the hills. Okay? The purpose of this is to increase surface area. Okay? So that means you can have more area to put your little friendly neurons, which is your nerve bodies at. Okay? Now, the brain is actually very well laid out in the way it's set up. Okay? The sensory components of the brain are the occipital lobe, which is responsible for taking all the information from visual. And then you have your temporal lobe, which is essentially a big area controlling your auditory area of the brain. Okay? And then you have your parietal section. So all your sensory components, in other words, are posterior to the central sulcus. That central big line here, and if you put everything in that side, that's all our sensory components. So more than 50% of our brain is responsible for just sensory interpretation. That's pretty cool. Okay? It's pretty well laid out. It's even. Okay? Look, it sends out 50% is just sensory, and the other 50% of the brain is going to be action. So you're 50-50. Okay? The back portion of the brain is all responsible for sensory. The front portion of the brain, which is called the frontal lobe, is responsible for what you do. Okay? It takes the sensory information that is mostly processed at this point, and then it puts the emotional content on it and decides what it should do. Okay? Without a frontal lobe, you basically lose your emotions, you lose who you really are, and you act very differently. The classic example of this was done not by any medical experiment, but it was done by accident. They had this young man, he was in the mid-30s. He worked for the railroads at the time, back in the 1800s when they were doing the transatlantic railroad. And one of the things that they would do in those days is they would take dynamite sticks and they would plunge them into holes in the ground. They still do it today. Okay? The difference is that these sticks, instead of being dynamite, they tend to be plastic or something else that's a little bit more stable. But in those days, the dynamite would sweat. And with sweating dynamite, you know what that is at all? It means that the nitroglycerin would sweat through the actual packing. Okay? And that means if you tapped it, it would explode on you. Okay? So it was a pretty dangerous job. Okay? You would take the dynamite into a hole, and then you would take your tapping stick and tap it into the ground to go all the way down. So when you exploded it, it would give you a good fracture, and then you would be able to dig out the area and put the railroad tracks nice and stable. But what the guy was doing when he tapped it, he had his face right over it. When he tapped it, it exploded, and it drove the rod through his eye and through his frontal lobe. Now, the patient was basically taken immediately to a doctor locally, you know, and then they had no neurosurgeons. So I'm sure all his job was basically to pack the wound and hope that he would survive, which most of the time people like that would die in those days. They just didn't have anything, no antibiotics. But the reason he survived most likely was because when the flange went through him, it was superheated from the dynamite explosion. So it went through him, it cauterized as it went through him. Okay, so he burned everything as it went through and basically prevented it from forming either infection or prevented it from bleeding to death. Okay? So this guy ended up surviving. Okay? And what's really interesting is how they knew this guy really well beforehand because he was a very religious man. He had like 4 or 5 kids. Okay? Very nice to his wife. He was a very good person. Okay? And after this injury, he became a person who began to drink excessively, womanize, did everything he never did before. Okay? So based on that, and after his death, they took his brain, which was several years later, and they examined it, and they figured out, well, you know what? Based on what we're seeing, the amount of extent of injury, the frontal lobe is responsible for emotional control. You lose that, you lose the ability to emotionally control somebody. Okay? Now, this became a very important medical finding, and it became eventually over time that we looked for disease processes to identify which portions of the brain do what. Okay? And by doing pathological exams after the patient had died, then we correlated to the clinical history, and then we could find out pretty much how the brain functioned. That's the only thing we had available for almost 150 years. Okay? It's only until recently that we actually have PET scans where we can actually see the metabolic activity of the brain taking place, that we can see and figure out what portions of the brain does what. When they tell you that you can only use 10% of your brain at 10% of your brain, what they're really telling you, that's really true, but what happens is blood shifts around your brain depending on need. If I'm doing high mathematics, I don't really need my frontal lobe to give me the emotional content of the mathematics. Instead, I need a certain different portion of my brain to do mathematics. If I'm doing something like I'm playing a piano and I'm listening to scales, then I need a lot of my temporal area of my brain. Okay, so that area lights up in the PET scan. So before that, we didn't have that kind of information, but now we actually have that kind of information. Okay, so we'll stop here, give you guys a 10-minute break, and then we'll start back up.